My name is Shtern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. My gratitude to Mr. Hall for the opportunity to present this first joint prostate cancer awareness event between AdMeTech and Urban League of Eastern Massachusetts. The focus of my talk is on the AdMeTech Foundation's history and our prostate cancer programs established to lead and implement the cutting-edge advances in patient care and to bring these advances to all Massachusetts men with the goal to eliminate health disparities. AdMeTech's ongoing statewide program in prostate cancer created a Massachusetts model of national leadership in public awareness, medical education, research, and health equity. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. We are grateful to Senator Miranda and other leaders of the Massachusetts legislature who have championed our programs and made them possible. History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of Diagnostic Imaging Research Branch at the National Cancer Institute. In this position, I was leading development of national and international policy and related strategy and programs for the National Institutes of Health, NIH, Department of Health and Human Services, and U.S. federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound, and molecular imaging for improved patient care. We also work on teleradiology for image transmission so that we could bring world-class expertise to underserved rural and remote communities. As of early 90s, most women had blind biopsies. Precision imaging made it possible to see where suspected tumors were located and develop stereotactic biopsies where biopsy needles are guided with precision to suspicious areas. As of early 90s, women with breast cancer have radical surgery or mastectomy, where the entire breast is removed. A procedure performed in operating rooms causing physical, emotional trauma, pain, suffering, and deformity of women's bodies. Precision imaging made it possible to proceed with minimally invasive surgery or lumpectomy, where we identify and remove only a part of the breast tissue containing tumors. These minimally invasive procedures are performed in outpatient clinics with minimal complications, pain, suffering, and costs. As of early 90s, many women, particularly Black women, were diagnosed with breast cancer in more advanced stages and were more likely to die. With digital mammography and MRI, all women are more likely to have early detection of breast cancer, critical for saving lives. Today, Black women have a nearly equal chance of dying compared to white women in many communities, particularly in a state like Massachusetts with its universal access to care. In 1996, while our breast cancer programs were well underway at NCI and NIH, I brought together the key leaders of government, medicine, and industry to outline new strategic priorities. This expert recommended prostate cancer as the next priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer is among women. Prostate cancer strikes 1 in 8 men. Breast cancer strikes 1 in 8 women. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or the likelihood of men dying of prostate cancer. However, men did not have accurate diagnostic tools that would make it possible to sort out if an abnormal screening result is due to false alarm or due to a life-threatening prostate cancer. With no accurate diagnostic tools, many men had either insufficient diagnosis and treatment of aggressive prostate cancer with dangerous consequences, or on the other side of the spectrum, they had overdiagnosis and overtreatment of benign and harmless prostate cancer, leading to unnecessary invasive procedures with related life-altering complications and costs. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to a prolonged hospitalization, difficult recovery, and the unacceptable level of life-altering complications. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, in sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care and eliminating health disparities. At about the same time in 1996, I had a personal experience that left me shaken. A leading clinical expert in Massachusetts, chosen by me, saw my father and determined that he had a benign and common prostate condition. However, when my dad had an invasive procedure for this condition, he was found to have prostate cancer. I was shocked that a leading expert in a world-leading hospital did not have diagnostic tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of this disease for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I organized other leaders of medicine, and we approached NCI and NIH, key leaders, in a hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track record and a year-long effort, we did not succeed in convincing federal government. Consequently, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. Since 1997, we have been leading a pioneering research that resulted in creating precision MRI, molecular imaging, and other diagnostic tools that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, Where is Manogram? Prostate Imaging for Men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, a leading health disparity, and public health priority. By 2013, again per our advocacy, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a standard in patient care. Since 2014, We expanded our efforts in public awareness, reaching countless men. At that time, Plymouth County had the state's highest mortality in Black men and the highest disparities. Black men in Brockton and Plymouth County were 2.7 times more likely to die compared to white men. We joined efforts with Brockton NAACP and Good Samaritan Medical Center. Under leadership of Steve Bernard, Phyllis Ellis, Leona Martin, and Janet Trask, Brockton NAACP ensured a broad community engagement, mayor's office, city council, local media, and multiple local community organizations. By 2021, we had seen a significant reduction of overall prostate cancer mortality for all men in Plymouth County, but a particularly great impact on Black men. Since that time, we have seen a significant drop in health disparities in Plymouth County, while health disparities at the state level have not really changed. Today, Black men's chance of dying of prostate cancer compared to white men in Plymouth County dropped by more than 50%. In 2016, we established Global Summit for Medical Education with the goal to integrate imaging with other emerging diagnostics, including molecular and genetic testing, to ensure precision care that was tailored for individual men. Similar to breast cancer, precision imaging paved the way for image-guided, minimally invasive treatment for prostate cancer. Similar to lumpectomy, these minimally invasive procedures can be performed in outpatient clinics with minimal complications, discomfort, and cost. Several years ago, in 2021, we created Prostate Cancer Equity Program to deliver high-quality, world-class patient care to all men in Massachusetts, with the priority focus on Black men. For public awareness campaign, our messaging centered on the importance of screening and early detection with blood test PSA, critical for saving lives. Since 2019, we reached well over 60,000 people. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive during the same period of time. PSA blood test used for screening of prostate cancer has been more successful in reducing the loss of life than any other cancer screening tools available today. Screening and early detection of prostate cancer are the best equalizer for all men. The centerpiece of AdMeTech's medical education is annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. There is not a corner of the world that has not been represented at our summit. The latest 8th annual conference took place only a few weeks ago. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It's particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and multiple branches of NACP located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities, particularly when combined with our large-scale public education and awareness campaign. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in our program take care of our families and friends. This process consists of three main components. First, AdMeTech Foundation team members collect basic information and match individual patient needs with the appropriate state experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, and financial assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech's team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention.